TopMedTalk.
All right, well, we are back day 3 of the annual meeting of Anesthesiology 2021, the American Society of Anesthesiologists. I'm your host, Desiree Chappell, and I'm joined by my co-host, Professor Monty Mythen. Hello, Monty.
Hi, Desiree. Good morning. Very good to be here.
It is wonderful to be here. And Professor Sol Aronson.
Good afternoon, and it is wonderful to be here.
Yeah, it's day 3. We've had amazing conversations. We're live here in the exhibit hall in sunny San Diego.
Brilliant. Everyone's having a fantastic time.
It is. Well, we're having our great conversations on TopMedTalk, which is the broadcasting arm of evidence-based perioperative medicine. And we've had some different series that we've been running throughout this last year on novel therapies. And at our meeting this last week, actually, at EPOM Ireland, we had some discussions about novel therapies, didn't we, Monty?
We did, and in particular, we picked up on a novel rescue antiemetic. We recorded a mini-series, which you can find out now on TopMedTalk. We should point out that one of our overall sponsors within the TopMedTalk platform is the company Acacia, that have released a new drug into the marketplace. And as part of that mini-series, we put together a piece at the beginning, a sort of mashup, that included an introduction to this drug that we had from our guest, who's coming up in a second now, at the European Society of Anesthesiology. Desiree, our guest.
It seems so long ago, but we had the opportunity to talk to TJ Gann, who we have again today. Dr. TJ Gann, thank you so much for joining us.
Delighted to be here. Thank you for inviting me.
Yeah, TJ, you've been a guest on TopMedTalk. You've been at our EPOM meetings. Tell us just, for those who may not know you, just a little bit more about yourself.
Sure. So, as Desiree said, I'm TJ Gann. I'm currently professor and chair at Stony Brook University in Long Island, New York, which is about an hour outside Manhattan. I've been there for the past 7 years or so. Before that, I was at Duke University and had spent some time with my friend and colleague, Dr. Mythen and Dr. Aronson.
I can't believe it's been 7 years already.
It has been. Time flies.
My goodness.
Yeah,
Wow.
absolutely.
There we go. TJ, now, sorry to dive straight in, but when we met you, I think it was in Vienna at the European Society of Anesthesiology. Anesthesia, is it?
Mm-hmm.
Who knows? I was going to say who cares, so I'm not going there. And you told us that there was a novel antiemetic about to be released, and that's now become a reality. And when you first told us about it, as we said in our series, it was a bit of a yawn because we thought surely we don't need a new antiemetic. But this one's different, addresses a new problem, and has got a different approval for use. Can you expand on that?
Yes, that's right. So this drug, the generic name is called Sulprite, and the trade name is called Barhemsys, and it's a drug that recently approved by the FDA for both prevention and, more interestingly, treatment of failure of nausea and vomiting prophylaxis. And it has now been approved, and it is a new drug under the class of dopamine antagonists. Now, many of us are familiar with dopamine antagonists, for example, droperidol and haloperidol. Interestingly, if you look at dopamine antagonists, there are really two subclasses. One is called the butyrophenone, and the other is called benzamide. So droperidol and haloperidol belongs to butyrophenone, and this drug, sulprite, belongs to a subfamily called benzamide. So there are some differences in pharmacology and some differences in, as well as the side effects profile.
What we heard from other colleagues that were interviewed in the mini-series that I said is out there, is that this is a drug that's been familiar to us for a long time as an anti-schizophrenia drug, for example. So in Europe, we've been very familiar with it. But it's realized that a much lower dose, it's an effective, and in particular rescue antiemetic, I think is the key component of it. Non-sedating and with very few side effects. Have I learned from interviewing for these podcasts? Am I all over it?
Monty, you are the fast learner.
Can we get Sol's input on that?
Well, my input is, I think, to sort of speak to your opening remarks. Another antiemetic, where is there room on the shelf? And speak to the differentiation and the need to fill that sort of gap in the continuum of antiemetic and PONV sort of therapies. And where does this fit, and what does that mean in terms of the realities of clinical care?
Right. So I think, we have a number of antiemetics currently on the market that we use for prevention. For example, I think one of the commonest used prevention antiemetics are ondansetron, which is now generic, and dexamethasone, which again has been shown to be effective. So the two combinations are very widely used. And in addition to that, sometimes we add a third drugs, either a prepton, which is an NK1 antagonist, or transdermal scopolamine. Now, there is also evidence to suggest that if one fails, which based on the data, about 30%, despite prophylaxis, is going to have nausea and vomiting in the recovery room. Now, it is in that setting that we find ourselves very lacking in terms of what antiemetics can we use for treatment of failures. The data suggests that if you have used ondansetron as prophylaxis, repeating ondansetron does not work. So you are basically no difference on giving saline. Dexamethasone is long-acting, so there is no good reason to repeat that. So, and some other drugs, the older drugs such as promethazine, Benadryl, they are incredibly sedating, especially on the doses that we use in the recovery room. And on top of that, like for Phenergan, there is a FDA black box warning for if you accidentally inject it outside the vein, it can cause extravasation of the drugs and causing ischemia to the limbs. And my pharmacists always want to take Phenergan off the PNT list. So we are faced with a situation that we run out of options in the treatment realms.
And
bingo. That answers the question.
Well, I'm just reflecting on the fact I've forgotten most of my pharmacology. I had a chance to do the exam twice as a medical student, which is a longer story. But the 5-HT3 antagonist ondansetron is pharmacologically very, very different to a steroid.
Correct.
And again, it's very, very different to the other drugs you mentioned. This is different again, so I'm guessing it's attacking the problem from different angles.
Yeah, you're exactly right. I think there are 5 different receptors in the what we call chemoreceptor trigger zone. That is a center for of nausea and vomiting. And ondansetron work on the 5-HT3. Dexamethasone, we're not still quite sure where it works, but it seems to be a membrane stabilizer. Then there is the histamine antagonist, which again is associated with sedation. And then there is the anticholinergic, such as scopolamine, which also have anticholinergic side effects. And then the other class is droperidol, which is what Sulprite belongs to. So the recommendation is to use drug from different receptors, because if one receptor doesn't work, maybe that nausea and vomiting is because of the other receptor mechanism.
And TJ, given those sort of different pathways to receptor specificity to treat and or prophylact nausea and vomiting, I can only presume that we could predict based on prior experiences and response that it may not even be worthwhile to pursue a dead end if we have reasons to understand that it hasn't worked in the past. Is that true?
Yeah, so I think there's a lot of evidence here that if you repeat ondansetron following prophylaxis, it's like giving saline. So it's not effective. And giving drugs in a recovery room that cause sedation, you're only going to prolong PACU stay. And we know that if you have an episode of nausea and vomiting in the recovery room, on average, the patient will stay half an hour longer. Now, in a setting where your PACU is packed with patients, you can't discharge patients from the PACU, that has economic impacts to the hospital. Even more so when your OR, trying to get the patient into a PACU at the end of the case, and where you can't, the cost of running the OR, as Dr. Aronson can tell you, is very expensive, right? The minute OR time is significantly higher than PACU. So you have that backlog of patient not being able to go from the OR to the PACU, and that significantly impact on not only flow as well as cost to the hospital.
TJ, should we do a better job of labeling a 5-HT1 non-responder, so that when I come back for my second and third and
That's a
sixth surgery,
great point.
that I'm not even given the opportunity to go down the protocol of first, second, and third choices because I've already been declared a non-responder. And what are we doing to label patients like that?
Well, I think that is where the consensus guidelines that we published just last year that specifically state that if you have given ondansetron as a prevention drug, do not repeat ondansetron when the patient develops nausea and vomiting. And that has been well shown by evidence, and we hope that when people read the consensus guideline, they can then learn from it and therefore do not practice or do not give ondansetron in their practice. So in our guidelines, we specifically mention that if you have used ondansetron as a prophylactic drug, do not repeat ondansetron when they have nausea and vomiting in the recovery room.
And not respond. TJ, we've talked about a little bit about those guidelines just for everybody if they want to get a hold of those, because I know they came out during COVID and were maybe overshadowed just a little bit. So where do we find all of that?
Yeah, so as is any consensus guideline, is only useful if you update it regularly.
Yes.
So we published our first one in 2003. And every 4 or 5 years, we publish an update. So the most recent one is the fourth update, which was published last year in Anesthesia NOGs. They're one of the premier anesthesia journal in the August issue. So, and also this is available, no charge.
Free.
It's free access to anyone who wants to use it. Go to ANA website and you can click for the full version of the guidelines. And in addition to that, with the publication of that guidelines, we also have a program where we can give what we call virtual grand rounds. So if your institution would like for an expert to present the guidelines, you can go to a CME website called CineMed, so CINE-med.com/PONV.
Yeah.
And there you can request for a program and register for it, and we can provide a virtual grand round. There's no cost to the institution or the participant.
Brilliant.
We're getting ready to do this actually, TJ, so I'm looking forward to hearing more.
Wonderful. Looking forward to it.
All right. Thank you so much for taking the time during the meeting this weekend. I know it's really busy for you, but we really do appreciate you sitting down with us and talking more about this novel therapy. So thank you.
It's always a delight to talk to TopMedTalk, and thank you very much.
Thank you so much.
All
Thanks
right,
for
TJ.
listening
Thank
to
you.
TopMedTalk. Find us at topmedtalk.com and ebpom.org.
TopMedTalk.
Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.